And I may need 5 more minutes if the chairs will not mind, because I try to make this a little bit more interactive. So one of the guidelines that were discussed in the last Congress was the update on the guidelines on pulmonary embolism. There are quite a lot of different new aspects. Of course, I will not go through all of them, but I will use a clinical case to illustrate how you can use the new guidelines in terms of management of patients with a suspicion of acute pulmonary embolism. These are some of the new aspects. You will find them all on the website, on the document, both the extensive document and also in terms of the pocket guidelines and the slides and the apps. As I mentioned yesterday and some of my colleagues, now you also have an app that you can actually upload to your iPad, to your iPhone, and use it at the bedside with your patients, with your students, with your fellows. So this is a typical case, a 73-year-old female. She's referred to the emergency room because she complained of acute dyspnea and dizziness lasting for the last 8 hours. Has comorbidities, she's obese, hypertensive, diabetic, type 2, with history of rheumatoid arthritis with severe functional impairment. She's on a statin, she's on an ACE inhibitor, beta blocker, and a blood glucose lowering therapy with metformin. Now, when we think about predisposing risk factors for venous thromboembolism, now we can classify them in terms of strong, moderate, or low risk factors for thromboembolism. And this has to do with many studies that can tell us what is, in terms of risk stratification, the odds ratio of a certain patient to have venous thromboembolism, which we know is one of the main causes of pulmonary, if not is the number one cause of pulmonary thromboembolism. So as strong risk factors, we have a whole list. I will not go through all of them, but for instance, we know that in many orthopedic instances, this is one of the major risk factors for developing venous thromboembolism, immobilization of the member, all the characteristics that make it easier to develop venous VTE. And the second, in terms of moderate risk factors, you can see a whole set of different conditions, including autoimmune diseases, which our patient has. She has a rheumatoid arthritis, and some other clinical conditions, like congestive heart failure, which is important in our case. We see a lot of these patients. So it's considered as a moderate risk factor, this different type of clinical conditions. And then we have the so-called weak risk factors. And in this case, the patient had diabetes, was hypertensive, had increasing age, and was obese. So you have now a whole set of different clinical conditions that can help you to risk stratify your patient, and we will see some risk stratifying scoring systems that can help us to risk stratify our patient and determine what is the likelihood of this patient having a pulmonary thromboembolism. Now, in the initial clinical examination, the patient, as mentioned, was obese with a BMI of 35, systolic blood pressure 88 millimeters of mercury, so hypertensive with a heart rate of 95. There was a swelling of the left leg. She was tachypneic with a respiratory rate of 28 breaths per minute. She had a PO2 of 6.2 with lactates of 2.5, and so high lactates, so was acidotic. And the pulse oximetry showed that breathing room air 87%, so hypoxemic. This is the ECG, and I think it's clear for all of us that, and this is, as I mentioned, the typical example. And I think we can see the classical pattern of S1 key 3, the McKim-White pattern. And we may also see some right strain on V1 and V2, which, of course, when we see this in a patient dyspneic, it always brings us to our minds the chance of being an acute pulmonary embolism. So we can also say that there are characteristics of the patients with suspected pulmonary embolism in the emergency room that can help us to make the diagnosis. And if we look at, and this is quoting some previous work, if you look at the whole set of patients who had confirmed pulmonary embolism and the patients who had not confirmed pulmonary embolism, there are some clinical conditions that can help us, but some are very non-specific. Well, in our case of our patient, the patient had both dyspnea, and she also had signs of deep venous thrombosis. Remember that she had a unilateral swelling of the left leg. And this is more common, of course, in patients who had confirmed pulmonary embolism. Now, there are a couple of rules, classical ones, which have been actually simplified in this new version, like the Wells rule, where you can use different variables like previous history of PE or DVT, tachycardia, surgery or immobilization, and so on. In our patient, the patient was tachycardic. She had clinical signs of DVT, and the alternative diagnosis less likely than PE, which in our case it seems very straightforward. So now the new development is to have a two-level scoring system, which basically tells you if PE is likely or unlikely. And in this case, in the simplified version, PE is likely if you have at least 2 or more of these different clinical parameters. So in our case, we do have at least 3, which classifies the patient under this rule as a high chance of having pulmonary embolism. There are other classical scores, like the Geneva score, which was also revised to make it simpler, and using some of the things are similar among these different scoring systems. In this case of our patient, the patient had tachycardia, she had pain on the lower limb, and she was over 65 years old. So 3 different positive clinical parameters, which classifies this patient, according to this system, also as a likely pulmonary embolism, because what you need now in this revised system is 3 or more of these rule points considered in this Geneva score. So these are basically ways of actually helping you to, again, risk stratify the patient from a diagnostic standpoint. So the question is, if you have a patient with suspected acute pulmonary embolism, the first question is the patient hypotensive or in shock, yes or no? If it's no, it means it's not a high risk, and we will see. If it's yes, then it means the patient is a high risk. And if you look at the original and simplified pulmonary embolism severity index, the so-called PSI or PSI, we can see that if you look at the simplified version again, according to the different parameters like age, like the previous history of cancer or current history of cancer, presence of chronic heart failure or pulmonary disease, pulse rate above 110 beats per minute, hypotensive, and with a PO2 of less than 90%, this gives 1 point, and this can help you again to risk stratify these patients, because basically, if you have at least 1 point, your 30-day mortality risk is about 11%. So just by having one of these points in a patient who presents with a suspicion of pulmonary embolism, it risk stratifies. And again, with this simplified version, you can actually have very easily the question on how likely is the patient to have pulmonary embolism. So again, now the recommendation for prognostic assessment, the initial risk stratification of suspected or confirmed pulmonary embolism based on the presence of shock or persistent hypertension is recommended to identify patients at high risk of early mortality. And again, this is a 1B indication. So let's see in our patient, which I think is clear that we have a high risk of the patient developing pulmonary embolism. She's stabilized by some supportive treatment, including the use of inotropes, while awaiting for the diagnostic workup. So which of the following imaging tests is the most appropriate for a definitive confirmation of a PE diagnosis? And I think you can start voting, either for pulmonary angiography, echo, CT scan, magnetic resonance, or a VQ scintigraphy. Maybe I will start giving you, going through some of them. Do we have the answer ready or not yet? Okay, so I will start just going through. I'm sure that all of you have voted. So for pulmonary, if you have the results, you can just show them, so we can see what the people think. But pulmonary angiography is not a first-line choice of imaging test anymore. We know there are procedure-related complications, and particularly in patients who have hemodynamic compromise. So this is not really a good option. Well, echo, of course, could be one option. And if there are any equivocal signs of right ventricular dysfunction, this may justify reperfusion treatment if it's a patient unstable, and particularly if you don't have access to the CT scan, which, as you will see, will be the right answer, although I would accept also here the echo if you don't have immediate access to a CT scan. MRI or magnetic resonance angiography, that is low sensitive, and there is a high proportion of patients who have inconclusive scans. And VQ scintigraphy, which again is another classical method of looking at pulmonary embolism, there is a high rate of non-diagnostic scans. So the right answer here will be C, but as I mentioned, we can also accept B if there is no immediate access to CT. And the reason for the correct answer being C is because there is a high positive predictive value in patients who have a high clinical probability, and this, again, it will help you to make the immediate clinical decision, which is actually what you want to know. Do I do reperfusion treatment in this patient or not? Or I just start anticoagulation? So this is the algorithm now. So if you have a suspected pulmonary embolism with shock or hypertension, if CT entry is immediately available, then it should be done. And then according to the results, if it's positive, then this patient should undergo fibrinolysis. If you don't have access to a CT entry, then echo should be the imaging method to be used. And you see here how much imaging is now at the center of the diagnostic algorithm in patients with suspicions of pulmonary embolism. And again, here you will look mostly at signs of acute right ventricular overload, as I will show you in just a minute. So it's a 1C recommendation now that in suspected high-risk patients, high risk of pulmonary embolism, as indicated by either shock or hypertension, emergency CT angio or bedside transthoracic echo should be done in these patients for diagnostic purposes. Now, the patient's hemodynamic status deteriorates suddenly while awaiting the CT scan. So she's more hypertensive, more tachycardic, more tachypneic, so basically doing worse, with 83% of pulse oximetry. You can see there are changes now even more severe in the ECG, with the widening of the QRS, axis deviation, it starts to develop some sort of bundle branch morphology, so clearly, and right strain, so clearly not doing well. So in this condition, it's so critical that it only allows for bedside diagnostic tests. So in this case, I think we have more or less the answers, so I will probably move forward. Which of the following tests will be of help in the emergency management decision? Plasma D-dimer measurement, well, there is low positive predictive value by using the D-dimers, and in patients with high clinical probability, it's not really the test that you should do. So shall we do assessment of PESI score, troponin and BNP testing? It's useful, of course, for the optimal risk stratification of adverse outcomes in these patients, while the high-risk patients require an emergency diagnostic algorithm, as we've seen. So really, at this stage, they are not so useful for the acute patient who is crashing basically in front of our eyes. The clinical probability assessment that I've shown you on the Wells test or the Geneva score, clinical probability is usually high in suspected high-risk pulmonary embolism patients. So we don't really, in this case, if it's a high-risk patient, hypertensive, getting into shock, we don't really need to go into more risk stratifications already at very high risk. So here, of course, is the use of echo and the evidence of right ventricular dysfunction or the right heart thrombi or proximal DVT, because you can also do ultrasonography, compression venous ultrasonography, are sufficient to give you immediately the answer to the question, do I need to do acute immediate reperfusion or not? So this is the echo of our patient, and this is a typical, I'm sure that you can easily recognize here, typical signs of acute pulmonary embolism, acute right ventricular overload, the classical McCullough sign, which is acute dilatation of the right ventricle with preserved apical contraction, but this is, again, compared to the left ventricle. The left ventricle usually is hyperdynamic if there is no baseline changes in terms of left ventricular function, as is the case. You can see the motion of the septum, which is also related with acute increase in right side pressure. And you see also the shift, which is also very nicely shown here of the interatrial septum, again showing increased pressure in the right atrium. And then one thing which is also typical of acute pulmonary embolism, we don't usually have very high pulmonary artery pressures, but we do have increased pulmonary artery pressure. You can see here that in the tricuspid regurgitation Doppler profile, you can see that the gradient between the right ventricle and the right atrium is 50, which if you add 10 of pressure, or even 15 of pressure in the right atrium, it will give you a pulmonary pressure of about 65, which is high, of course, but is not extremely high, which is also something that we see in many patients who present with acute pulmonary embolism. So primary reperfusion is a strategy is considered, of course, in this very high-risk patient. So in this case, which of the following items is false? Systemic thromboembolysis is a treatment of choice in this setting. I think, considering what we've just shown, it's clear. Surgical pulmonary embolectomy should be considered as an alternative. Percutaneous catheter-directed treatment should be considered as an alternative. Parenteral anticoagulation should not be initiated until the diagnosis of PE is confirmed, or absolute contraindication to thrombolysis might become relative in a patient with immediately life-threatening high-risk pulmonary embolism. So the false, which means the correct answer in this case is D. Immediate parenteral anticoagulation should be initiated while awaiting the results of diagnostic tests in patients who have a high or intermediate clinical probability of PE. And these are the patients, I'm sure in the discussion we may get into that. I will not get now very much specific into that part, but these are the patients who should be started on parenteral anticoagulation, either with the, most likely with an unfractionated heparin or with the long lateral weight heparin, and not immediately on NOACs, because that, I'm sure it will come when to use NOACs in these patients, considering some of the trials and some of the recommendations now that can be used. But in the very high risk, who will likely can undergo thrombolysis, we should wait at least for a couple of days and see if the patient evolves or not into a situation that he or she will need thrombolysis. Because if the patient needs thrombolysis, then it's not good to be on a NOAC. If not, then we can start with NOAC, and then we can start the classical anticoagulation. The classical now is the new NOACs, the new anticoagulation schemes. So it is recommended to initiate intravenous anticoagulation with unfractionated heparin without delay in patients with high-risk pulmonary embolism. It's a 1C, and thermolytic therapy is recommended. It's a 1B indication now. And again, we may have to consider in some cases surgical or even percutaneous catheter-directed treatment, which is one for the surgical treatment if for patients in whom thrombolysis is contraindicated or is failed. And the percutaneous catheter-directed treatment is also considered for this patient as a 2A indication, which means that it should be considered for this specific subgroup of patients. So we have here now the algorithm, which basically comprises all these different aspects that we discussed. So if we have a clinical suspicion of pulmonary embolism, shock or hypertension, yes or no. If the patient is with acute evidence of severe pulmonary embolism, then we should follow the diagnostic algorithm that we just seen. And then this is a high-risk patient, and it's a patient with indication for primary reperfusion. If it's not the case, if the patient is not in hypertension or shock, then we should risk stratify the patient and use the different protocols that I've mentioned. We can calculate what is the clinical risk of this patient, and if it's a very low risk, then consider early discharge and home treatment if feasible. But if it's, which are probably the majority of patients that we see with suspicion of pulmonary embolism, if it's an intermediate risk, then this patient should undergo imaging, either echo or CT, and if both are positive, then in this case it's an intermediate high risk. This patient should be, of course, admitted and monitored, and these are the patients where we have to wait a couple of days to see how they evolve. If under anticoagulation they stabilize or not. If they don't stabilize, we may have to undergo reperfusion or other techniques to remove the thrombi. Otherwise, we will continue with anticoagulation. If it's intermediate low risk, this patient should be hospitalized and started on anticoagulation. And this is basically here summarizes in a very nice algorithm how we should now manage patients with pulmonary embolism. And with this, I will finish. I'm sure there will be many questions. Now, this is a very important area from a clinical standpoint. But
Dear doctor, your time is up.
I know. Thank you.
Thank you, Pastor. This was really terrific. Very comprehensive, and you hit on the very practical points. Just as from the interventionalist perspective, if lytic therapy fail, or maybe we should ask the question, when would you go to mechanical treatment?
Well, if thrombolysis fails and the patient is still hypotensive, still in shock, and we have evidence that we could not remove or do thrombolysis, if thrombolysis does not work, if we still have clot burden significant, then these are the cases which are extreme, as you know. We don't see this all the time. But these are the cases where you have to do whatever you can, because that's life-saving. You know, either you do that or the patient will die. So those will be the patients that you should consider.
I want your opinion about two things. The philosophy of the high D-dimer before doing the multi-dye CT, and the second, the use of inferior vena cava filters. The adjunctive treatment in patients with pulmonary is after you inferior vena cava filter, IV filter, yeah. And the second, the role of D-dimer before doing CT. If it's a high, the false D-dimer, or with the high D-dimer influences with clinical suspicion directly into the CT.
Well, again, of course, you can use, because it's more information that you have, but as you've seen here, particularly for the high-risk patients, or the patients who present with hypertensive or in shock, you should go straight to imaging. So I will not worry too much. Of course you can have it, but I will not worry too much about the D-dimers. For the filters, you do if you have recurrent thromboembolism, and we do see that in patients, in the cancer patients, patients that sometimes we don't really understand why they do it recurrent despite being on anticoagulation. So these are the ones that you should identify for vena cava filters. I have to say that over these last years, I don't know why, maybe because we have better anticoagulants or whatever, I have not seen a lot of these patients. But occasionally we do have these patients, some of them with prostate cancer, or patients who develop some sort of a more hypercoagulable state that we cannot really keep well anticoagulated. So those are the ones where we put, if you have evidence of recurrent embolism.
We have some cases when you suspect pulmonary embolism and you do duplex and you don't find thrombi in the GPAs. We found such cases a lot, and then the decision making becomes so weird. So what do you think would be the possibility of this pulmonary embolism if it's high suspicion, and how would you deal with it?
Yeah, well, if you don't see the thrombi, it could have migrated, so it does not mean that it was not there before. So that's one thing. So in fact, actually, it's also on the guideline, and it's not. If you don't see a thrombi, it does not mean that there was not a thrombi there before. Particularly if you have some conditions that make it easier to develop thrombi, and we do see that a lot. You know, you do the Doppler study, ultrasound study, and there is nothing special. So here, I think you have to use, first of all, the risk stratification scoring systems, which will put you on high risk of developing pulmonary embolism or not. And then, maybe I'm a little bit biased, but I think imaging here is fundamental. You know, and again, if you have a high suspicion and you confirm that you have some evidence of right ventricular strain and right ventricular overload, even if it's not major, and even if you don't see a significant amount of clot, if you do a CT, of course then you can do it if the patient is stable, and if you still have some suspicion, you can have additional testing, you can have a DQ scintigraphy, although the rate, the sensitivity and specificity is not so high, particularly if you have pulmonary disease, for instance, in these patients. So I would say that if the suspicion is high, my threshold for, because the question is anticoagulated or not, so my threshold for anticoagulation is relatively low. So if I have a patient with a high scoring system, with some evidence of right ventricular strain, I would anticoagulate.
Would you agree to the statement that if you suspect massive or submassive pulmonary embolism, don't go to neural anticoagulants because you don't know the next? You agree about that?
Yeah, well, I mentioned that. If you have a suspicion that you might need to use thrombolysis, wait until the patient stabilizes or not, and if the patient then underwent thrombolysis, these are the patients that you don't want to be on the NOACs, at least for the moment, because we don't have data to support that. So these are the patients that should not be started immediately with the NOAC, in the very high-risk patients.
I want to ask you about a very specific situation where you have pulmonary embolism following a major surgery, for example, spinal surgery or something like this. How safe is it associated with hypertension? I mean, how safe is it, the fibrinolytic therapy in these situations? And if we can deliver the fibrinolytic therapy locally via something like Clearware or something, or should we resort to mechanical extraction and thromboaspiration or something? Well, what do you do in these situations?
These are the cases that you have to decide on an individual basis, because of course these are the very high-risk patients. So it depends on the extension of what kind of surgery. If it's a kind of surgery where the likelihood of increased bleeding can be significant, if you have, for instance, neurosurgical or any other sort of surgery that by doing fibrinolysis you can actually develop major bleeding. So in these are the cases where you may have to balance what would be more beneficial. Of course, these are the patients also who have a worse prognosis, because if you underwent major surgery and you develop a massive pulmonary embolism, these are the patients with very good prognosis. So also these patients are the ones that you tend also to take a little bit higher risks. So I would balance, I would use here clinical judgment, depending on type of surgery, the risk of the major bleeding. If I calculate that the risk is acceptable, and if there is a major thromboembolism, then I would probably go for thrombolysis. Otherwise, I would do anticoagulation, and if it's major thrombi, I would try to do for a mechanical dissolution of the thrombi. But these are the difficult cases that you have to assess on an individual basis.
And one last quick question.
I want to ask about surgical embolectomy. About surgical embolectomy. There is some trials about surgical embolectomy, massive embolism, when patient is contraindicated for thrombolytic therapy. What's your opinion about, and what's the guidelines say about this? The guidelines, or
the guidelines say that you should consider it if the patient has contraindication. Exactly what we were talking about. If the patient has contraindication for thrombolysis, and there is evidence of massive pulmonary embolism, then you should consider it. And particularly if you have the setting available to do it. I remember I have actually in my portfolio of cases, a couple of cases, while doing, I remember one case of a lady that she was getting ready to go surgery for cabbage actually, and she crashes in the intention of anesthesia. So we just put the transesophageal down the lady, and she had massive thromboembolism. So therefore, immediately she underwent surgical extraction of the thrombus. I actually published that some years ago. So, again, these are the patients who have contraindication for thrombolysis, major pulmonary embolism, evidence of big thrombi. Here you have to go for a mechanical solution.
Okay, thank you very much, Dr.